We'll learn more about those as we get into trauma. But whenever we are looking at the airway, we want to make sure that we assess the chest. That means we need to remove the clothing, right? If you have an unresponsive patient. Now, if you have a responsive patient, it's kind of awkward to go in and just take their shirt off and look at their chest, isn't it? But if they're unresponsive and a victim of trauma, well, then they're not going to be able to tell you if they have a flail chest or if they have a hole in their chest or something, and you need to check that. Now, one thing, and I know it is an awkward situation for some, especially when you're a rookie. All right, because especially guys, you get embarrassed because you have a female there and you have to cut their shirt off. But let me tell you, you do not want to go into the trauma bay and a woman with big breasts has a stab wound underneath the breast. And they have a pneumothorax and they have a sucking chest wound there, because you will get your butt crawled. You are professionals. You will do it. Same thing, ladies. It's the same way for the ladies. You get embarrassed. I understand. But we're professionals. You have to go above that, right? So you have to assess the chest and make sure that there are no injuries there that could potentially compromise breathing. If you have a sucking chest wound, which is a wound that's in the chest and it makes a sucking noise, and it's because air is supposed to go in and out of your mouth and nose, right? When it comes out of your chest, that's not a good thing, because the air does not go into the alveoli like that. It gets into the lining of the lungs. In between, there's a potential, there's a lining, a membrane that lines the lung called the pleura. You have the parietal pleura and the visceral pleura. There are two linings. And there's a little bit of fluid in there, and they move like this. Well, sometimes air can get in the middle, and next thing you know, you have a pneumothorax. And every breath they take, they're sucking air in, making that pneumothorax get bigger and bigger and bigger. Now, what ends up happening is, as that pneumothorax gets bigger, it pushes on the vessels of the heart. The vena cava is one of them. So let me ask you something, because we all know the 21 steps of blood flow, right? So what happens when that vena cava gets pinched? What are you going to see? What's going to happen? The vena cava is pinched and blood's not getting to the heart good. So what are you going to see? Now think back, use the 21 steps. Come on, I've been giving you the answers.
Huh? It's not going to make it to the veins quick enough and everything.
Well, the veins are full because the vena cava is right at the heart. So it can't get into the heart. Huh?
You're not going to have circulation.
Where?
The rest of the body.
Oh, come on, y'all think about it. Where does the blood start? Start at the vena cava, right? So we start at the vena cava, right at the door of the atrium, right? So let's say that the kink is before that, okay? So the blood's going to go through the atrium, to the tricuspid valve, to the ventricle, right? Through the pulmonary valve, to the lungs, does that circulation, and comes back to the other side of the heart, right? To the atrium, bicuspid valve, the ventricle, then the aorta. Then to the aorta, to the arteries, arterioles, capillaries, venules, veins, and there's a red block. There's a red block right here.
Can't get back in the heart.
Can't get back in the heart, so what are you going to see?
Discoloration at the top of the blood will pool.
Huh?
The blood's going to pool up.
The blood's pooling up. And where are we going to see it pool?
I don't know.
In the veins. Well, JVD, what do you think? That's why you're checking for JVD. The veins are pulled because it can't get in. It's a big like roadblock. So it's barely getting in. So what's blood pressure going to do? No, it's going to lower because nothing's come out because they can't get the blood can't get to the heart. So whenever we're checking blood pressure, we're checking the arteries, right? So the veins are full of blood, but the arteries are like empty. See, use the 21 steps. You figure it out. What's going on? You'll see the JVD. You'll start seeing the veins distending. They're getting full of blood. Blood can't get back to the heart. And every time a patient takes a breath, that pneumothorax is getting bigger and bigger. And that's when we need a paramedic to come take a needle and stick in the chest and relieve that. And it gets all better for a little while. Save their life, right? Alright, so when we're assessing breathing, what are we listening for? We're listening for normal breath sounds, wheezing breath sounds, rales, rhonchi, stridor, and pleural fiction rugs. That's what we're listening for. So normal breathing is an effortless process. It shouldn't affect speech, posture, positioning, but labor breathing, you'll see the patient getting in position to breathe. They'll do what we call tripod, where they're use their hands to brace themselves. They'll purse their lips. You'll see accessory muscle use. They'll only be able to use 2 or 3 words. So here we have the sniffing position, and then we're tripoding. Trying to expand the lungs to get as much air in there as we can. So it says circulation. It says pulse rate, pulse quality, pulse rhythm. Identify external bleeding, and evaluate skin color and temperature. If they have major bleeding that's life-threatening, you'll stop it. If it's not life-threatening, you'll just ignore it and move on. Assess the pulse. Assess it if you have a responsive patient, radial, unresponsive, carotid. Whenever I have an unresponsive patient, I'll check the carotid and the radial at the same time, just to assess both. Ranges here, tachycardia, basically for an adult is greater than 100, bradycardia is less than 60. And here it's a good idea to kind of get an idea and memorize your normal ranges for pulses. So assess your circulation, your pulse quality. A normal pulse is strong. A stronger than normal pulse is bounding, and a pulse that's weak or difficult to feel is what we call weak or thready. Weak and thready, same thing. So how are you going to get used to figuring this out? Feeling your pulse, feeling other people's pulses. If you're not taking time at home to practice these things, then you're setting yourself up for failure, okay? So practice this on other people. Look at the rhythm. Is it regular or irregular? You're not going to diagnose exactly what it is, just is it regular or irregular? And irregular is whenever the interval between the 2 pulses are at different lengths. Like most of the time, most of us should have a beat about once every 2 seconds. If it's fast, or once a second, it's 60, right? So if you have a pulse, and then 2 seconds later you have a pulse, and then 5 seconds later you have a pulse, and then 2 seconds later you have a pulse, and then 6 seconds later you have a pulse, that's irregular. The skin, normally we're warm, dry, but if you're cool, clammy, and diaphoretic, that's not a good thing. That's a sign of inadequate perfusion.
Shock.
Yep, went into shock. Like I said, with the color too. Typically we do skin color and temperatures all one swoop. Not good, little blue baby, right? So when blood's not properly saturated with oxygen, we get this cyanosis. And that means they need what?
Circulation.
Need oxygen or circulation, but usually oxygen will help. So skin temperature, normal skin will be warm to the touch, 98.6. Abnormal temperatures are hot, cool, cold, and clammy. Skin moisture, typically we're dry. But also keep in mind, if it is 100 degrees outside, like it gets here in Georgia in July, you may be sweaty. But if you walk inside the house and they've been in the air conditioning and they're still sweaty, that's typically not a good thing. Capillary refill. Capillary refill is where we pinch the thumb or the nail, and when we release it, we time the amount of time that it takes for your nail bed to turn from white back to pink. It should not take more than 3 seconds. If it takes longer than that, well then we can assume that there could be a circulatory problem. The problem is that it's not really reliable in some patients. You have patients with medical problems like high blood pressure, or they're chronic smokers, and they have some chronic respiratory problems. You could have some skewed results. And here we're checking capillary refill. Especially in children, it's a very good indicator. Typically children don't smoke, they don't have high blood pressure, and they don't have those problems, right? So, if we have a circulatory problem, we want to try to restore circulation as soon as possible. One thing that we can do is stop bleeding. Because every red blood cell that's spilled on the ground is one less red blood cell in the body to circulate. And everyone can count. So we want to stop bleeding if needed. Sometimes just laying them down will help. Giving them oxygen can help. If there's no pulse present, start CPR.
Assess for and control major bleeding. Assess the patient's pulse rate and strength. The patient's skin should be assessed for color, temperature, and condition. Initiate shock management, including keeping the patient warm and elevating the patient's legs if indicated.
Okay, so when we have someone who's bleeding, if we have bleeding from a large vein, that's typically a steady blood flow. A large vein can produce enough bleeding to be serious. But usually venous bleeding is not very serious. Or capillary bleeding is not very serious either. But bleeding from an artery typically produces spurting bright red blood. And they can lose a lot of blood quickly from it. So if you see that, you want to do something about it and immediately control it. So here, we're going to identify and treat any life-threatening bleeding that we can. Remember, in the primary assessment, we're only identifying and treating what? Immediate major life threats, okay? So, whenever we are also treating our patients, we also want to always remember that we are going to never stay in a linear process. It's always going to be a process of evaluating something and reevaluating other things that we've already evaluated. If your patient, while you're assessing circulation, if they become in a state where they have an airway obstruction, well, guess what you're going to do? You're going to stop the circulation portion and do what? Fix the airway, because airway comes before circulation. If the patient stops breathing, you're going to fix the breathing. If the heart cannot function without oxygen, then that means that we have to ensure that we have an airway and the patient is breathing. We can go longer bleeding than we can without oxygen. The brain cells start to die in 6 minutes. Well, it depends on the type of bleeding, but you know. Alright, so now that we've kind of gone through that section for circulation, we want to do a rapid scan of the body. This should only take about 60 to 90 seconds to perform. It's not an in-depth exam. The only thing we're looking for, again, is life threats. Yes, sir?
No,